Welcome to HealthTalk TV. Treatment strategies in mantle cell lymphoma have changed fundamentally with new options across first, second and third line. Today we will discuss emerging strategies in mantle cell lymphoma with Professor Martin Dreyling, lead investigator and first author of the TRIANGLE study, which has, I will say, significantly influenced first-line treatment strategies in MCL. Welcome, Martin.
Thank you.
And we have also with us Jon Riise, head of the Department of Oncology at Oslo University Hospital. Welcome and thank you for taking the time.
Thank you.
So let's start, Martin, with a kind of helicopter perspective. What do you see as the most important change in how we treat mantle cell lymphoma today?
I think we have tremendously improved treatment of care during the last, well, let's say 20 years. Initially, we somewhat intensified chemotherapy only, and that led us to some success achieving longer remission durations. But however, now we switch from chemotherapy, from cytostatic, to targeted therapy. Well, that, of course, only works if you find the Achilles heel of the disease. And at least in mantle cell lymphoma, we have some strong indications that this one is the B-cell receptor pathway. So targeting with Bruton's tyrosine kinase inhibitors, we really improve outcome, also long-term outcome, if we combine it with our standard of care.
That's interesting. So that has been the new guy in town the last 10 years, BTK inhibitor.
Absolutely. This has become the new standard of care. And to look ahead, I think we're now challenging chemotherapy overall, maybe substituting by intelligent combinations of targeted therapy.
So Jon, if you take the Norwegian perspective, what do you think has changed in how we treat MCL patients in Norway the last 10, 20 years?
Yes, as Martin said, it has been a tremendous development for mantle cell lymphoma the last 20, 25 years. With introduction of cytarabine, high-dose chemotherapy and maintenance with rituximab, which has significantly improved the survival and the duration of responses. Of course, with the addition of the TRIANGLE study, you have lifted this even more. So now, if you see back 20 years, I would say twice as many is alive after 5, 6, 7 years today than there were back 20 years ago. So that's a significant improvement.
Yeah, that's very interesting at a high-level perspective. Let's just now go deeper into the lines. Let's start with the first-line therapies, which absolutely is for patients that is newly diagnosed, of course. There is clearly not longer a one-size-fits-all way of treating patients, I guess. So we have different strategies and depending on age as well. Martin, you were the lead investigator and first author of the TRIANGLE study, as I mentioned. What do you see as the most important measures from this study?
I think what we have proven is that the addition of the BTK inhibitor does improve overall survival on the long range. And that is the strongest parameter, not only the strongest parameter, but really means that whatever you do at salvage therapy, you will not catch up. That's very important. So I think it's really critical to apply the best and optimal first-line treatment. Having said that, I already mentioned the next step is to challenge chemotherapy, and we already challenged it partially because we compared high-dose consolidation against the addition of BTK. And one pill a day, in fact, was better than the old standard of care with high-dose chemotherapy. However, high-dose chemotherapy achieves a lot, but also has a lot of side effects. And therefore, by cutting out the high-dose consolidation, we're also improving tolerability of this kind of treatment.
Does the result of this study mean that we should rethink the automatic use of autologous stem cell transplantation in younger patients? Or
Absolutely.
Yeah. So we should really stop doing that.
Not totally, but for the vast majority. So what we could prove is that, in fact, for standard risk patients, which are about 80% of patients, we in fact do more damage the patients in that way that we introduce toxicity based on high-dose chemotherapy. However, there are the other 20% high-risk patients, and this is not driven by the clinical score, the MIPI we established, but biological parameters like high cell proliferation and p53 alterations. And in these cases, there may be still a role for chemotherapy also in the future study generations that had been at least suggested by both the ENRICH trial and the Altamira trial, where they tried to skip chemotherapy overall.
So what about the fragile, the more elderly patients? How do we treat them? Do the study you led, does this have an answer here as well?
It's an interesting point. Like in CLL, where we used to compare young fit patients being treated with fludarabine at that time and older patients. Now, as we are shifting away concerning our strategies, this age limit, is being softened. What do I mean? With the TRIANGLE trial, I think this is applicable at least in the fit patients up to year 70. Whereas for the older regimens, let's say older patients regimens, they somewhat start, let's say, at age 60. We all have these patients with comorbidities. So this is now really becoming probably an art how to pick the optimal treatment for the patients between, let's say, what I would say intermediate age, 60 to 70 years.
Yeah, very interesting. From a clinical perspective, you have been for some time using this the combination from the TRIANGLE study. So what are your experience using BTK inhibitors in the first line?
What Martin said was that in the study you had 3 arms. You have the standard of care, and you had the standard of care plus BTK inhibitor. But you also had a 3rd arm where you took out the high-dose chemotherapy with stem cell transplantation and only took the pill a day, the BTK inhibitor. And that's a brave study that you actually take something out also. Usually you always add something. And so that means that you don't have to give to the vast majority of the patients in first line young. You don't need the high-dose chemotherapy, and that means it's more tolerable. And you have less side effects, and it's less time in the hospital. So this is of course a regime that we think is really effective, and it's better tolerated, and it's less resource intensive for the hospital. So it's like you have all 3 in one basket. So
that's a very positive use of resources. And
I think that's also why we just recently got a group exception before Nye Metoder or the decision board had their approval, because also the government saw that we can't wait.
That's quite extraordinary in Norway, that they really can use the method before it's really approved by decision forum. So thanks to you, Martin, for making that possible.
Well, thank you. And in fact, I would like to emphasize this was an academic trial, so it was really set up by the European MCL network, not by any company. And in fact, this trial also led to the official European registration. So that was the first time ever, at least for me, where we have been successfully transferring academic trials right away into clinical practice.
That's exceptional. That's very rare that you have.
So can I ask you, how did you have 3 arms?
Right.
The 3rd arm, as you mentioned, it's quite bold. How did you get to the conclusion that you really would like to try to take out some standard medicine? So how did you arrive at that decision?
That's a very good question. In fact, we were discussing exactly about this point for about a couple of years when we set up the study. And some of us were more conservative and said, well, let's keep the autologous transplant based on our decades-long experience and just add something. And the other half said, well, we want to look forward. We want to get rid of at least part of chemotherapy. And to be honest, at a certain point, I gave up. I was really desperate and said, well, okay, then let's keep 2 experimental arms.
Yeah.
And then our statistician calculated and said, well, you need 870 patients. And I said, well, maybe that's the end of the story, because in such a rare disease, however, the people who were so intensively discussing that point, they were also actively contributing. So this study had been performed in 14 countries all over Europe and Israel. So I think that really shows you how bright minds can really push the field forward.
Really? So an academic study, that's extraordinary. You had a lot of patients, over almost 900 patients. So that's quite some time, and I think it also went quite quick. You made the study quite quick. That's impressive.
Quicker than expected, and luckily the size of the study also gives us the chance to investigate subgroups. So this is now really a treasure where we can really say, well, these patients will specifically benefit from this kind of approach.
Yeah. So what's the point of moving forward from this study? Do you have other plans for new studies?
Well, I already mentioned, now is the point to maybe challenge chemotherapy overall. Our US colleagues and also some European colleagues, we have already done some studies where we skipped chemotherapy and have seen high response rates. However, we don't know the very long outcome. One has to be fair. And the only chance to define that is really to have a randomized trial, head-to-head trial. And these trials are going on because it's also, we didn't mention that, it's not that easy to combine these 2 approaches. For example, with a high-dose RRC, there had been some tries to combine that with BTKi, but the problem was toxicity. So therefore, you really have to be very careful challenging the new standard, that you're not losing something or adding up too much toxicity.
Based on your experience, what do you think about the new study to taking out chemotherapy in total? Is that too progressive? Or
it depends on which group you're thinking about, because we still have groups which is challenging. It's some high-risk patients where we don't have the expected effect as we see as in the whole group, and we have elderly or old patient that is not cannot tolerate the triangle. So I think first I would focus on trying to solve for the high risk or the one that don't have the tolerability for the triangle eye. That's at least where I see the highest unmet clinical need today.
So the triangle study is definitely groundbreaking, I would say, but we have also other studies which are interesting in this field. We have the ECHO study and SHINE, exploring BTK inhibitors in combination strategies, and we have Altamira, where also quite a lot of Norwegian or Scandinavian patients has contributed, and endres study suggesting chemo-free approaches for older patients. So how do you in the clinic combine all this knowledge, and how do you help the patients in the best way?
And here's, of course, some of the access will come in, at least in Norway. Yeah. It's a little bit easier in Germany, but for patients which is not fit or young enough for a triangle, we today will have in first line only bendamustine combined with rituximab, for example, which is, I would say, the standard of care for the elderly population. But to have access for like Altamira, where you only have a BTK inhibitor combined with rituximab, would be a fantastic approach for the elderly patients. We had the Altamira and Enrich. We also participate in Triangle, so we can see that this monotherapy, or not monotherapy, but only BTK and rituximab is very well tolerated, and you have durable remissions for a long time. So, and the patients are really happy. That's something we really want to have in clinical standard practice today.
Yeah. So to both of you, so you think that mandatory chemotherapy is not in the short run, but in the long-term perspective, it will be excluded?
Maybe in long term, but it's difficult to take out something which works so well as triangle eye.
Yeah.
So I would have evidence in other groups before I dare taking out the chemotherapy for the young and fit, where you want like a 20-year remission.
Exactly as Jon is saying, because you lose also, or there is a risk of losing something. However, we learned from CLL, there we had exactly the same discussion about 10, 15 years ago. Why should we skip chemotherapy? It's so effective on the long term. But then at some point, someone was so handsome just to try it. And surprisingly, the new compounds were more effective, not only better tolerated, but also more effective. So mantle cell lymphoma, I would say, is the older brother, the worst disease in comparison to CLL. Therefore, we're not going for targeted monotherapy. We have to, compose intelligent combination partners. And we always, like always in oncology, we have to look at efficacy, but we also have to look at side effects. Sure. And there's always a balance about that.
Okay. So that was the first line. I think that was a tremendous good discussion. Let's, of course, unfortunately, a lot of patients relapse and move into the second line. What kind of alternatives or strategies are preferably for these kind of patients, Martin?
I think what is very important to remember that first-line treatment dictates or guides salvage treatment. So essentially, as we are switching first line, we are also switching our strategies for salvage. Now, in the patients which nowadays relapse, which are mostly being pre-treated with chemotherapy only, standard of care is BTK-I, monotherapy. That is the official label. But that is gonna change, because once we start with BTK-I containing first line, we may move on concerning our salvage treatment. Having said that, however, in Triangle we applied a trick, and the trick was time-limited maintenance. So we stop after 2 years, whatever happens, and thereby we already now know that if patients relapse, they relapse much later. And the idea is, the hypothesis, it's not proven, that we can re-expose them with BTK-I.
Exactly.
However, to what extent this is really the case, we will see in the triangle with a longer follow-up of this study.
Do you see the same perspective that when you use BTK in first line, there is a risk that, well, why should you, what's the rationale to introduce it in the second line as well?
Yeah, of course, I agree, totally agree. So but today the best available, the best method we have available will be to real challenge with a BTK-I. But we also have access for Tecartus or the CAR-T treatment.
Yeah, absolutely.
But that's after you have been through 2 lines of therapy.
Yeah.
So that's so today it's a bit challenging because we are moving the BTK inhibitor in first line, and depending on how long you have the treatment-free interval, that will affect how easy it is just to re-challenge with the same therapy.
Exactly. But still, BTK inhibitors have drastically, historically, over the last years, improved the hope that patients will live much longer. So that has totally changed the landscape also in phase 2.
Well, absolutely. For the long-term outcome, sequential outcome, we have not yet proven. One has to be careful. However, we do see exactly that point, and if we say BTK-I is preferred in salvage treatment, this is all evidence-based medicine. So this is all based on comparisons between the old standard, which had been chemotherapy, and again, 1 pill a day was better than chemotherapy in relapse disease. That was unexpected at that time, but the data are the data, and this is why it became mentioned as preferred treatment in all national and international guidelines.
So we discussed in first-line treatment the difference between young and fit patients, of relatively young patients and older. Are there any discussion about how to treat these two groups also in the second line treatment, Jon?
Since BTK inhibitor or BTK inhibitor is the preferred treatment, which is well tolerated, I would say we could give that to most patients.
Yeah.
If you don't have specific cardiac problems, there's some limitations, but mostly as long as you have been BTK naive, you haven't had a BTK inhibitor in first line, I would say that both for young and for elderly, you will prefer to have a BTK-based treatment. And of course that could be added with something else, but we don't have access to most of those targeted possibilities.
Exactly.
But Jon addresses an important point, which is, and now I will address the white elephant in the room, what about first and second generation BTKIs?
Exactly.
So in Germany, luckily now both are registered in either first or second line. And here age plays a major role. So what we have experienced in the TRIANGLE trial, that were the super fit patients, the young patients. And there really the cardiac side effects you mentioned, which are atrial fibrillation and coagulation, that was really a minor problem, but that was really the super fit patients qualifying for autologous transplant. In older patients, and we have to be aware that in demographic or epidemiological data, median age is in around age 75, something like that. And there we do have these challenges. And then I think it's an individual decision, and one has to be fair. Concerning efficacy, there is really no major difference between these two classes. But when it comes specifically to a coagulation, when it specifically comes to atrial fibrillation, there the second generation BTKI are better tolerated.
Is that the same perspective you have, Jon?
Yeah. So we have access for second generation, but we don't have the pirtobrutinib, and which will be a different class of BTK inhibitor, which would be easier to use in a second line if you had received the BTK inhibitor in first line. But
is there also the third generation BTK inhibitors? Is that also an interesting perspective? I think pirtobrutinib is on the horizon, I think.
Yes, and it's important to emphasize it has a different mechanism of action, and therefore it may also overcome resistance to first generation or second generation BTKI, the covalent ones. It's a non-covalent one, it has a different mechanism of action, and therefore still about 50% of patients are responding to pirtobrutinib, which became refractory to first or second generation BTKI. So although it's the same naming, it's a total different thing.
I see from the studies that pirtobrutinib that is more beneficial for fragile patient. Is that correct, or is it one size fits all?
Well, this again, I mentioned we're totally evidence-based, and there is a trial going on. Recruitment is completed where exactly these two approaches had been compared head-to-head. Unfortunately, we don't have the data so far. So I can't answer your question. My feeling is, and again, this is a gut feeling, this is no evidence, that pirtobrutinib is better tolerated, whether it's really as efficient or maybe even more efficient than first and second generation BTKI. We have to wait for the results.
But it is interesting. It has a different mode of action compared to the second generation, which probably, in theory at least, could we think that it will be beneficial for people having had first line BTK that could be introduced to the third generation type?
Yeah, so it could overcome at least some of the resistant mechanisms for BTKI first and second generation. So
that's very interesting. I think. Are there other things to say about the second line before we move into the third line?
Maybe one thing, but I do agree that this only partially applies to Norway, probably because of registration. So when we consider a disease more aggressive, then we move on from monotherapy to combined therapy. At least we try to. And this is the same for BTKI. So we try to move on to targeted approaches, and one standard approach, at least in CLL, is BTKI plus venetoclax. And this has also high efficacy specific in the high risk patients. And what is even the most important risk factor, and that's in all kind of diseases, is duration of first remission. So essentially, if the relapse is early, within 1 or 2 years, in lymphoma we frequently talk about POT24. Now these patients are usually difficult to salvage, and in these selected cases we consider more combined approaches.
Very interesting. Will you add to that, Jon?
No, I agree, but we haven't used that yet because we don't have access. But it's of course it's an interesting combination.
That's the difference between which we talked about before this broadcast. We talked about the German system and the Norwegian system. You say yes to everything, and then you decide if it's cost effective. We make the cost effective decisions before using it. So,
but I have to be honest. If I'm talking about these combinations, this is not registered, also not in Germany. Yeah. And I'm old enough. I knew the old system where if you had solid data to prove that, you could also apply off-label. But that is the past.
Yeah, exactly. So let's move to the third line, which is very exciting. Of course, we have a lot of patients relapsing into the third line, and quite recently we have a new drug, CAR-T, which can be used. And we use it in Norway quite a lot, I know. So what is the experience with the CAR-T treatment in Norway?
So CAR-T in general we have mostly used for DLBCL, which is another more prevalent lymphoma, and where CAR-T is, has been a very important development for the treatment.
There we use CAR-T, yeah?
Yes, that's correct. So in mantle cell lymphoma we have experience of roughly 1.5 years. And since also mantle cell lymphoma is fairly rare compared to DLBCL, we have not that many patients, but we have a few. And this is also influenced by real-world studies where we see that CAR-T is not maybe, the responses isn't as long as they are in DLBCL, and the toxicity is higher. Yeah. So it's a little bit more difficult in this population than compared to DLBCL, but obviously it's an important development, and it's an important treatment for those that it fits. Yeah,
so it is not a fixed solution like we see in DLBCL. We have the plateau with people reach very quickly, so they live definitely longer. So it is not the same experience that you have in MCL with CAR-T.
And it's also worrisome that it's also more toxicity long term. So we see that we have more problems with infections and other long-term side effects, which is a little bit strange. We don't know exactly why they are behaving differently, but that's at least the experience both for us, from our side, and also what we see in long-term data.
So for Martin, what is your perspective of the realistic possibility for patients using CAR-T? Do you find the same challenge as Jon mentions?
So Jon is absolutely right, and this is not fully reflected in the published literature. So what we do see initial responses, but again duration of remission is shorter. And this is a general theme, we know that, but we have also seen it in CAR-T cells. So it's not the magic bullet which solves all of our problems. However, I strongly believe immunotherapy in general will become standard of care and the backbone of salvage treatment once we move on with BTK-I in first line. And what we now try to do, again, combine it in an intelligent way, because we know that at least the first generation BTK-I, and here a disadvantage may become an advantage, is less specific. So it also turns on or blocks, better said, some enzymes which take care of fitness of T cells. And these are the T cells, the CAR-T cells are the T cells of the patient treated in a specific way, and that you just they can hunt again the B cells. And taking advantage of this mechanism, combinations may be specifically beneficial. Whether this is the case, we have to prove in a prospective trial, but I do agree that also we have to take care of toxicity, at least with the first CAR T-cell compound. We have a problem with neurological side effects.
Yeah. So based on that, how do you decide which patients are eligible for CAR-T and not? That's a different
question to you.
Well, that's a good question, and that's difficult. Of course, age has something to say, but it's not like a wall that happens at a specific date. So age, frailty, comorbidities, how fast the disease is developing, if it's rapidly developing versus if it's a more slowly developing. That will affect what we could expect of both the treatment and the effect of the treatment. Yeah. So this in combination, and of course other possibilities will always also be on our mind. What, do we have another possibility that could be as good, a study, or something else that could be better? Yeah. So you have to try to balance all these
exactly. So this is of course difficult for communicating to patients. We say, oh, sorry, you can't have CAR-T. So what are the options for the patients not having a CAR-T? Is that a good option, or is it? I
think at least for the time being, CAR-T cells are still our best approach at that time point of the patient's career. Having said that, it's exactly as Jon mentioned. It's a balance of toxicity. So CAR-T cells are better tolerated than any kind of transplantation, fair to say. So it's not a clear-cut age limit at 60. However, there are some patients with serious comorbidities where you would really caution that. On the other hand, you have to balance that against the danger or the risk of the disease. Exactly as Jon was saying, the progressiveness of disease. And based on this one, we mentioned pirtobrutinib. Pirtobrutinib is really a good alternative for the smoldering, slowly progressing disease. So these are well off with pirtobrutinib. The aggressive ones, there you only gain maybe 1 year or even less, one has to be honest. So this is what we all have to put together in a package and then also discuss with our patients. Some patients don't like to move to another place for treatment, and I learned this is a frequent approach in Norway. So this is, at the end of the day, it's a decision with the patient, not about the patient.
Yeah,
totally agree.
Yeah, absolutely. So advising other clinicians, what should be the takeaway, do you think, when they have patients and the possibility to introduce them to CAR-T, or what should they do? Should they only focus on fitness or age, or what's the perspective?
So we have a national CAR-T MDT board. So we discuss every week from the all university hospitals in Norway. So my advice is, of course, to bring the patient to this meeting and discuss it, and have the experience from Radiumhospitalet, where I'm working, but also from Trondheim and Bergen and Tromsø. And I think we have looked at the data we have from the LBSL and our experience with CAR-Ts, and we see that we do quite well compared to both the registered study and the real world data. So I think this approach to have all the knowledge, at least in the country, combined and try to do the best evaluation is the important way forward.
So it's basically a team effort, a team decision. Yeah, exactly.
And I can only support that, and just to add on that, always consider clinical trials, because this is how I see that these kind of academic trials, this is an additional chance for our patients. It's not a risk. Well, there's always a risk. Life is risky, but how I see the balance between potential benefit and risk of unexpected toxicities whatsoever, I think that we have limited options of treatment at that time point, and there I think really considering a trial, if a trial is active, that is really preferable.
So now we have, based on Suma2, we have the CAR-Ts, which we use in Norway and probably, I guess, also in Germany and the rest of Europe. But there is a second CAR-T, it's Breyanzi. It's not introduced in Norway. I think it is introduced in Denmark and a lot of other countries. Are there any differences between those two CAR-Ts?
I think the core difference is that neurological side effects are much less, so it's much better tolerated. So we exactly talked about the CAR-Ts where it's a balance of efficacy and side effects. Now this balance is much better for Breyanzi. And then if you go to really the small details comparing the study results, it seems to be that the CAR-Ts is more effective. And there are also some initial indications also in other kind of disease. However, if you look closer at the study details, you see the data are quite comparable. So I think now we have to be honest, CAR-Ts or Axi-cell was just our first step to move into the field of CAR-T cells, and now the fine-tuning starts. It starts with quote, bispecific CAR-T cells. It starts with better tolerated CAR-T cells. So I think this is just the start of the story of immunotherapy in lymphoma.
So we also, which you spoke a little bit before, we will probably see that CAR-T also will move into second-line treatment quite soon, I think.
Yes, and we have already some lucky support by our national health insurances. They made already a general statement. However, it's still the point what Jon mentioned, that it's an individual decision based on risk. So the very early relapses, young patients, young fit patients, I think there it is the first choice.
That's very, yeah. What do you think about that, Jon?
I agree with Martin. You know, the CAR-T to move the position, depending on, now we will give BTK in the first lines with the triangle eye. And the problem is that the approval is for 2 lines of therapy. So we need some adjustment with the guidelines to adjust for that, but we are pragmatic and will of course have the patient's best in top of mind.
Yeah.
So we try to find solutions that makes it possible to give the CAR-Ts and closely monitor the patient, which is rapidly progressing our first line, so that we are able to give the CAR-Ts at the correct time.
So we're approaching the end of this interesting discussion. I think it was a fantastic discussion, which we should try just to summarize the single most important point or the principle in MCL treatment today. What is that?
That is, as I said, we're moving away from unspecific chemotherapy to targeted treatment, and at least I do believe that BTKi is the Achilles heel and will remain a cornerstone of also future treatments, at least for the next 5 to 10 years.
Will you add something to that, Jon?
I would just say that it's fantastic to see the development we've had. I can't actually, no other disease in cancer come to mind that has had this rapid increase in survival the last 20 years, and that's fantastic to see.
I think that was a good ending of the discussion. Thank you to both of us for enlightening us and helping us to understand the clinical trials, treatment strategies, and also real-world practice, I think, which is, of course, important in mantle cell lymphoma. Thank you very much for taking the time, and thank you for watching HealthTalk TV.